Hey, everybody. Cassidy, founder and creator of the Caregivers Hub, coming to you today. This is December's Caregivers Hub Hangout. If you don't know what the Caregivers Hub is, it is a support group for caregivers. Anybody providing physical, mental, emotional, or spiritual care to another human being is welcome within our walls. We have medical professionals, we have family caregivers, we have volunteers, we have speech therapists and nurses, and we have all sorts of people. And I'm so excited that we are having this Caregivers Hub Hangout today, because the best thing about these is that I'm always looking for people to come out and talk to you guys about different caregiving topics. And basically, this is your platform to create awareness, for us to get together and talk about the challenges we face, about the things that we do. So I want to welcome you to the Caregivers Hub. Like I said, we do these the first Sunday of every single month at 5 p.m., although we adjust times like today because people are all over the world here in the Hub. So on that note, I'm going to quit rambling. I want to talk to you about what we're going to talk about today. We're going to talk about quality over quantity in healthcare. Guest, we connected probably about maybe 3 or 4 months ago. My guest and I, and she is an ARNP. She's a practical nurse, and her name is Laura Bramlet Wilkrson, and she is from Michigan. And I loved the minute that I saw Laura's videos you were talking about behaviors in dementia. And that always gets me excited, because that's always like my favorite thing to kind of figure out, little puzzles. So she has awesome information for you guys about what ARNPs do and how she has, from what I gather, you have evolved your care company around the philosophy of quality over quantity. So I want to talk about what that means to you. So on that note, I'm going to quit talking and let Laura come out and introduce herself and tell you her story.
Well, thank you so much for adjusting the time for me today. I really appreciate that. And thank you for. So, yes, I am a nurse practitioner. Some people do call us advanced practice registered nurses. What that means is that I have obtained a degree higher than the baccalaureate degree, like a registered nurse would. So I actually have my master's degree. And what a nurse practitioner can do varies state by state. So in our state here in Michigan, we have to have a supervising physician, which just happens to be my husband. And so
right on.
Yeah. And so he collaborates with me, supervises the work that we do. And if myself or the nurse practitioners or physician's assistants that work with our company get stumped or have something that we have further question on, we have him as a resource, along with some of our other doctors and specialists that we work closely with. So as you said, and I was telling you a little bit before we started that I've been doing this for about 14 years now, taking care of geriatric patients in their home, shut-ins, as some people would call them, people who have difficulty getting out. And I was previously working for someone else, and about 4 years ago, it'll actually be 5 this year, I decided to basically start my own company. And it was right about the time that my grandmother got sick. She had a stroke in her home, and she lived independently for quite some time, but then her congestive heart failure caught up with her, and she became unable to live alone. So she went and lived with my mother. And my mother was taking care of her for quite some time, and she did a lovely job. My whole family actually did a very lovely job. They all kind of stepped up and helped out with my mother, taking care of my grandma. But what I saw was that my grandma's care, while she was proactively seeking, positive, while she was actively seeking proactive care, her care was very fragmented. Nobody was talking. She'd go to a cardiologist and they wouldn't talk to her primary. Her primary wasn't talking to her cardiologist. And then when she would go into the hospital, it was very fragmented at that point. And heaven forbid she went to rehab because nobody found out what happened there. So what I did when I opened Advanced Medical House Calls was I created a system where it almost becomes like a medical home. And I don't know if you have those where you live, but basically every piece of information that if a patient goes to the hospital, it comes back to us while they're in the hospital. We're alerted when they're admitted, get a midway note, and then we get a discharge letter so that we can get that patient what they need prior to their discharge. So if they need hospice care, if they need skilled nursing or therapies, or even durable medical equipment, hospital beds or toilet seats or anything like that, we can definitely have that arranged for them before they come home.
Awesome. Well, you know, that kind of sounds like, now that I'm thinking about it, we had this meeting we have these monthly meetings with hospice, and kind of like this, people come and talk to us, and we had, I don't know if you guys if you're familiar with the term care manager, and it was a company. It was kind of like what you're talking about. It's like, that's what they do. And I think it was private pay with what she was talking about. But basically, they are the advocate to move them, you know, to represent them as a client or a patient. So they're not providing care, but they are communicating, you know, all of the things that you were saying. But the term out here that I've heard is care managers. Like, it's a legit thing.
It kind of sounds like a patient advocate. That's what we call that here.
Okay.
And that's if somebody doesn't have a family member or somebody to speak on their behalf, that they've got somebody that can help them or take care of them. But actually what happens is when a patient becomes homebound and they can't get to their primary care doctor, usually their primary care doctor will contact our office, or the patient will know somebody that knows of our agency, and they will contact us and ask us to take over their primary care. So as an advanced practice nurse or nurse practitioner like I am, we can actually prescribe for the patient, you know, so their medications that need to be refilled monthly, we can do that. We can advise them what medications might not be necessary anymore. A lot of times I'll see myself and my providers that work with me will see somebody go into the hospital that's, you know, 90 years old, obviously has some dementia or some behaviors, and they'll come out of the hospital and they'll be on Namenda and Aricept. I can't think of, you know, sometimes those kind of things are inappropriate, but, you know, that's kind of like a standard go-to. So definitely doing a lot of med reconciling, a ton of education. We recently hired a registered nurse to work in our practice, and she is running a program called Chronic Care Management. So that is a Medicare-approved program where if somebody has 2 or more conditions that are going to last through the end of their lifetime, she contacts them proactively every month and talks to them for 20 minutes, or sends them educational materials, or their family member or their caregiver, whoever that may be. And it's a proactive approach to handling education. I wish a lot more doctors would take the time to put this into their practice, because it actually, you know, primary care physicians spend an average of 5 to 10 minutes with the patient when they've come into their office. You know, you spend most of your time with your CRNA or your medical assistant taking your information and taking your vitals and chatting away, but then the doctor comes in, you've got about 5 minutes to tell them everything that you need. And then out the door, you with whatever it is that you need in hand. Our visits typically take anywhere from 45 minutes to an hour. We spend a lot of time hands-on with the patient, and then a lot of time educating the families. But those questions that come up later, they can either call our office or like I said, they're in our chronic care management program, and Sheila will contact them proactively to start setting up a care plan that's individualized around their care needs.
That's so great. And you're right. I think industry-wide, and not just, it seems to me like medical professionals and family caregivers, we're at this impasse where we're not communicating with each other. or not effectively anyways. And people are getting lost in translation between the hospital to the rehab to home, and things fall through the cracks, and people, and so it's, now that I'm thinking about it, somebody said, because I've always talked about this, bridging this gap between medical professionals and family caregivers, that there is this gap between us where we kind of, I think, sometimes when we deal with difficult family members, we automatically deem family members of kind of a pain in the butt. And, family members can sometimes deem us as medical professionals pretty incompetent. And you know what? To their credit, I feel like they've had a lot of fuel to their fire with that, because sometimes we focus more on what has happened negatively in healthcare as opposed to what's happening positively and the positive outcomes that we're having. So it's kind of given this stigma that healthcare workers are incompetent and that we don't listen to our patients and that we're not providing them the care that they need. So I'm glad that you have this philosophy around what you're doing, because it makes a difference.
It absolutely makes a difference. I think that in just the short time that we've implemented our chronic care management program, which I feel is very quality based, I've seen our hospitalization rates go down about 20%, and we've only had this program for a couple of months now. Our hospitalization rates are not very high to begin with, just because of the type of care that we do give. But implementing this program was definitely beneficial to our practice.
Yeah, well, I mean, I basically, because that way you guys can handle their needs via the phone in a lot more of an efficient time than it would be for somebody to come in and see their primary and go through all that struggle. Where, I mean, because in hospice, at least here, our volunteers do tuck-in calls every week. So that basically means that our volunteers are calling all of our patients' families, making sure they have all of the supplies and medications that they need to get through the weekend. So it kind of sounds to me that that's kind of like a little tuck-in call. How are you doing? What can I do for you now? I think that's great. It's awesome.
It's absolutely a tuck-in call. And I mean, from everybody in our practice, starting from intake to our patient care coordinators, I mean, it's huge. I believe that our practice communicates very well at the start of intake. They start to assess those needs that the family may have, and then the intake coordinator communicates that to the provider and to Sheila, our chronic care management nurse. And all of those pieces, just even intra-officely, I mean, are huge. Our staff is fantastic. They listen to what the patient needs, and then they make sure that the provider, because obviously Medicare can kind of be a stinker sometimes with the way that they will approve or disapprove, that hospital bed or that oxygen that needs to be there when they get there, or that medication that they might need. So, right. But all of these things start to add up. And all of these things definitely contribute to a person's quality of life, even though you might not think about it. A raised toilet seat for somebody who has, terrible osteoarthritis or rheumatoid that can't really bend to get there. Those kind of things are pretty important. And if we're not taking the time to educate our patients and our family members about what's out there, they just don't know. I mean, there's this big abyss of information that, people just don't know where they can tap into. So groups like this are very important.
Absolutely. Which is why I love it when people want, like yourself, want to come out and talk about what they do and about the care philosophies that they have, is because this gives us the opportunity to work together. I'm a firm believer that teamwork makes the dream work. So I will go above and beyond to communicate. I probably drive my nurses bananas, but I want to, I had this one scenario. I have a Vietnamese family, and so language is a very big thing. Like, it's very difficult for us to communicate. So like the things that I need to know are the, when was your last bowel movement? And if they've had a fall or if they're in pain, so I can report those things to my nurse. And getting the information, even with interpreters. Is there an interpreter available? That's kind of the thing. Those poor interpreters, I often think about all that they have to deal with, and they're stretched so thin. But communication is a big deal in this industry, and the lack of it. So how do you feel like your company and your philosophies and what you're doing with healthcare right now is different from the norm?
Well, I think part of it is just, well, I'm going to toot the horn for nurse practitioners. I really think that nurse practitioners are the wave of the future. Physician's assistants as well. I think with the primary care shortage that we're experiencing, with the changes in healthcare that we're experiencing, I think you're going to see more and more primary care physicians, pulling out. A lot of them are doing things like urgent care or cash for fee-for-service. But in this patient population, that Medicare eligible population, that's just not doable. I mean, the mean age in my practice is 88 years old. So, they're I mean, everybody is on a budget for sure. But I definitely think that this age group is certainly more vulnerable to that. And to pay fee for service is just not going to happen for them. So I think the fact that we have advanced practice nurses, we have physician's assistants working with our patients, I think that makes a huge difference because, and I will always say this, I'm a nurse first, and you can't ever take that out of me. So we definitely learned to be that person at the patient's bedside. We, learned to listen and be there. We didn't have to rush in and we didn't have to rush out, of their room. So I think that plays a huge part in the type of care that I give. And secondly, when I hire people, I hire people that fit the core values of my company.
I love that. That is so important.
It is huge because, I spend 90 days training my staff. Which is big, but I definitely want to make sure that they're a good fit and that they're following the same kind of care that I would give, which is treat everybody like I would treat my grandmother. And when people ask me questions like, well, Dad's having behaviors and what would you do about this? And I would literally say, well, if you were my father, you were my mother, and this was my grandparent, this is what I would do. This is
I think that's so important
at this point, but I'm going to tell you my opinion, and then I'm going to tell you medically, and we'll come to some sort of agreement together. And when we do, then we'll document it and make a plan of care for your loved one.
Absolutely. Oh, that makes me so happy because I think that that's what we need, and I told this story to my and at my IDT, I had a patient and she was a deep meditator, and she very much almost her anxiety was almost non-existent because she had been so diligent over the last 40 or 50 years of being a chronic meditator and being able to calm and quiet herself, And she told me one day, everybody who comes in here says, I need lorazepam. But I don't need any lorazepam. I mean, she almost took it. It was kind of funny. She almost took it to offense a little bit. Like, how dare you? I'm a master meditator. I don't need no lorazepam. But in that moment, I realized, it's our job, of course, to care for people and to fix all the things that are going wrong with them, or address those issues. But I think oftentimes we end up putting all of our knowledge and our experience and our skills on people. Does that make sense? Where we're just medically vomiting all over them about what they should do and how they need to do things and what they need, as opposed to, listening to what they need and using our skills and our knowledge and our experience and the resources and tools that we have to tailor that plan of care around that person's mental, emotional, physical, and spiritual needs. That's how I feel it should be.
Well, and I definitely think that you're right. I mean, that's why God gave us 2 ears and 1 mouth, you know, to definitely listen. And I've always said this, and I will say it from here on out. If you listen to that patient long enough, they're going to give you their diagnosis. They're going to give you that path of care. And if the patient can't speak for themselves, if you watch their body and you watch their actions, you know, not everybody that has dementia that's behaved needs Seroquel and Depakote. You know, sometimes they need, you know, pain management. So if you watch that body language and you watch that person, I mean, sometimes my biggest job is going and sitting in an assisted living facility and just observing that patient. It's not putting my hands on them or talking to their family, but it's watching them as they're trying to walk, or watch them as somebody's trying to transfer them. You know, is their facial grimacing? Are they, you know, contracting up and tight? Is their belly, you know, rigid and they're guarded? So definitely, absolutely 100%. I believe that it's all about individuality. You cannot, not a one size fit all medical care anymore. And I think that's what makes us different. And I think that's it as well. It's not a one size fits all. It's a how can we fit you?
Exactly. Oh, I love it. I love it. I'm so excited. That's what I'm saying is, I hope, you know, I was talking to my friend, she's an LPN, and we often have these conversations about our frustrations in healthcare. And, you know, we were talking about it, and she says, well, you know, it's just going to take a lot of people getting together and creating a movement. And I thought, you know, I think that's the difference too with the hub is, and with myself personally. You know, you asked me before we got on here, what made me do this? What made me start the hub, and what makes me cut on these videos, and what makes me talk to you guys about what I do as a CNA and about how I see healthcare in general. And it is because I'm tired of the status quo that this is just how healthcare is. And I hold myself to a high quality of care when I'm caring for people. And I just am of the philosophy that as medical professionals, that's how we need to be. You know, I mean, I get a lot of feedback a lot, especially when I have other patients that aren't necessarily my normal patients, that, you know, they're oftentimes, and it's not to discredit anybody's work, it's just oftentimes I will hear, you know, you approached me differently, or you're so gentle, or you make, you know, people come and they just kind of jostle me around. And, you know, I'm such a stickler for that. That's kind of how I feel about it. Because oftentimes in hospice, what I do when I go into, I just want to say for the record, as I'm going to go off for a second, hospice care is on top of care. It is not in lieu of care. Okay. So when your hospice aide shows up, that doesn't mean you bail. You know, it means that we are on top of care, not you don't provide care because we are providing care. We are both providing care, just so you know that. But yeah, I get a lot of that, that approach where people sometimes don't have that approach, where they are reverting to meds for combativeness and things of that nature, as opposed to just approaching it from, you know, how maybe it's something different, like you said.
Well, there's a lot of good information, you know, and I encourage people to definitely be selective with what they watch. You know, there's a lot of good information out there, and then there's a lot of not so good information out there. So I think places, you know, like this are a good place for people to learn from other people and from each other. You know, and again, it's not a one size fits all. So as I often check in the mornings, and I'll check Facebook in the evening, and I'll kind of read people's comments. People may be complaining about and I shouldn't say complaining. That's not a good word. I'm sorry.
Venting.
Bad choice. When they're verbalizing about what's going on with their loved one, it may be somebody in the top of the lead is talking about the same thing in the bottom of the feed. But those two people definitely need to look at, when people are giving them their answers, thinking about, what is it that my loved one needs, not just what is that one size fits all.
Right. Absolutely. Because we're all different. We're all different. So everything affects us differently. Maybe some of us are more spiritually aligned. Maybe some of us are mentally unstable. Or, maybe all of us caregivers are mentally unstable to a certain degree. But I definitely agree with you 100%. And one thing that I had heard the other day was, we talked about placement. And one thing that I see a lot in the hub is, should I place? When do I place? And oh my God, I have placed. And now I feel like the worst person in the world. So I really would like to talk about your philosophies behind placement, and, kind of just give me all your goods about placement.
Sure. You mean like when is it time for placement?
Yeah.
For sure. I think that changes I think that, again, it's not a one size fits all. It's definitely an individualized approach. But I would say that the Alzheimer's Association has a really good caregiver assessment tool. And it's one of the tools that we actually use in my practice. So when we meet our patients in their private home, one of the things that we do is we do a caregiver assessment tool, and it actually looks at the stress level of the caregiver. If that's high, we start to talk about things that they can. I know that
crazy high,
but a lot of people feel like they are obligated to stay with their loved one at all times. They don't know that there's resources out there. So if your loved one is fairly independent still, and there's no risk, like they're not combative, there's no self-harm to them or to you as the caregiver, I mean, then I think that's okay. And I think that you can find some good outside agencies, totally depending on your financials, or a friend to come over and alleviate you so that your loved one can, stay at home.
Mm-hmm.
But again, now keeping in mind the mean age of my practice is 88 years old. So if I am fortunate enough to have a husband and wife team, you've got to remember that they're caring for each other and sometimes compensating for each other. So if one of them goes down to the point where they can no longer move, their mobility is impaired, that is another key signal for me that it might be time to start looking for placement. And there's different kinds of placement too. You have independent living, which is, your basic apartment. And then you have independent living with services. And I don't know if you have that there, but we definitely have. And then there's assisted living units that are open, and assisted living units that are closed with locked doors. And then there's memory care units, obviously, as well. When I did own an assisted living, what I found was that we had an assisted living unit, and then we created our memory care unit, but there was definitely this in-betweener that really didn't have a place to go. So when I talked to my partners, I said, we really need something called a transition unit, which is like, they're not a two-person assist quite at this point, meaning that they need two people to help them, and they're not a complete feed, but they're definitely, got some wandering behaviors or something like that, and they need that transition spot. Which again, wandering out of the house is definitely another sign that it's time to start seeking placement. When you're loved one out of the house.
We've had a lot. I don't know if you've noticed any like in your local area, but we've had a lot of people with Alzheimer's and dementia out here who, they finally reach that point and they don't have care, and they get in their cars and they go, and one lady ended up in a retention pond, 98. They left, I just think sometimes it's really about the education and about what happens with Alzheimer's and dementia. And, that, well, they may be fine at 8 o'clock, but at midnight, all hell could break loose and they're out of the house. So it's definitely an issue for sure.
Absolutely. And again, it's another one of those things where I look at it and I say, we're having, 3 people diagnosed with dementia practically, every second nowadays. So it is that much more important that we continue to get the word out there, that people continue to share their stories, that people that have knowledge continue to share it in a way that is informative and helpful to other people. It's not our job to judge somebody when they put their loved one in an assisted living facility. There's a reason that they've done it, and there's a reason that they want to speak about it. It's our job to be non-judgmental. To downplay or to put somebody down for putting their loved one in an assisted living facility, I'd much rather have them do that than suffer medically themselves. And that's what will eventually happen. That person will either break down physically or break down mentally because they can no longer handle what's happening in their home. So I encourage everybody, if they start, if their back is aching all the time and they're not feeling well all of the time, and they once were, maybe now it's again time to start seeking placement, because their health is important too. There's a time and a place where you need to become the daughter or the son or the relative or the spouse of the person that you're caring for, and no longer, you'll always be their caregiver, their number one caregiver, because you love them and you want what's best for them. But there is a time and a place where it is appropriate to become just their loved one and give up that caregiver responsibility. You can always be their advocate, and you can always be their loved one, but maybe it's time to start giving up a little bit of that caregiving responsibility.
Absolutely. And that's always one thing that's one thing that I didn't realize until I started doing live-in shifts as a caregiver, exactly what that toll took on, 24/7 caregivers. It's an incredible toll. And I know that some of you who are watching this are thinking, self-care, what is that? I can't place my loved one, and living with the guilt with that. And I think that we have to get over this stigma, like Laura said, where we are judging each other for placing people. There's no shame in saying to yourself, I just can't do this anymore. I can't do this physically. I can't do it mentally. I can't do it emotionally. I can't do it spiritually. I can't do it financially. There's a lot that is upon you guys as family caregivers. And I agree with everything that you're saying as far as placement goes. Don't be afraid to do it, and know that it is okay.
Absolutely. And I would encourage people that when you start to look at those, other placement environments, that you go unannounced. And I encourage my patients' families and loved ones to do that now. When you are trying to decide between assisted living A and assisted living B, make an appointment to go there and look at it. Because you're going to think, well, they prepped, they set the stage, they had things just right when I got there. It smells like apple pie in here because they fresh baked it just for me. And
they smell nothing like apple pie.
Right. So I encourage people to definitely go unannounced. That's when they're going to find that building is running like it does every day, whether you're there or not. I tell people, notice how many staff are on, how are they dressed, how are they groomed, are their nails 6 inches long and, you know, bejeweled. We don't need those kind of things when we're in an assisted living environment. Find out, you know, their nutritional, their menus. They usually have menus to take with you. What are the smells that you smell? Does it smell, sorry everyone, but does it smell like urine? Because if it does, you can pretty much assure that's probably not the place that you want to place your loved one.
And because that means somebody's been sitting in it for a while.
For sure. And or that the furniture is not taken care of.
That's true.
So I mean, definitely look at those things and think about those things and find out how many people are on shift and how your laundry is done. And then, excuse me, find out the cost and find out, is it an all-inclusive cost? Or is it a cost that can go up depending on the level of your loved one's care? There's a lot of places around that have your programs where as your loved one declines, yeah, sure, as your loved one declines, their care is going to become more costly. Well, if you're putting your loved one who's 70 into an assisted living, you can rest assured that they're not going to be getting any younger or better. So you can assure that if you can't already, or if it's tight for you to afford the $5,400 a month, that the $7,000 or $8,000 a month that it's going to go up to is going to be even tighter for you at a later stage.
Which is what to be honest with you, which is what I run into a lot in assisted livings out here, where I'm having people come on hospice services who are in assisted livings and they, you know, maybe they have the basic or maybe they have a little bit more than that. And it never fails that as people approach end of life and actively transitioning, their care goes up exponentially. And what I'm running into is their families can't afford that care, you know? And so it kind of becomes a thing where they don't have very many options. Either somebody's going to come into that assisted living and they need to provide that care, whether it's a family member or an agency or whoever. But what I'm seeing a lot of is they're in these assisted livings on services. And once that care gets bumped up, now families are having to reevaluate putting them in adult family homes because the cost is cheaper, and you know they can get a higher level of care in an adult family home sometimes than they can get in an assisted living or independent living, which is kind of almost, to me, I kind of hate that. I don't know how you feel about it, but it kind of drives me bananas that here in this extreme time of need, like actively transitioning, we are uprooting people and moving them. Like, at the end of my days, somebody just get me the main package that has it all covered so I don't have to go anywhere. You know, I just think, that's what I'm saying. We need to reevaluate a lot of things.
There used to be a couple of primary hospice homes around here where you could actually go to transition, go to die.
Right. Mm-hmm.
But a lot of those were closed when Medicare made their changes. But there is a lot of financial help out there that a lot of people don't know about. Anybody that's a veteran, you know, you're entitled to veterans benefits. So I would encourage you to seek your local veterans agency and ask them what it is that you need. And it's quite a stack of papers that you have to fill out. But it can entitle a veteran anywhere from, you know, $1,000 a month to right around $1,300 a month, depending on their dependency. Mm-hmm. So that there's money there. A lot of people in their 70s and 80s also have something that is called long-term care insurance. Mm-hmm. Their children are digging through their files as they're placing mom and dad. They might be looking through some old paperwork and they might find this, especially the railroad. The railroad was very big at selling long-term care insurance. So those people that are retired from the railroad, you may want to look through your loved one's paperwork to see if they have that long-term care insurance. And certainly it is available now. It's making a comeback. It's kind of costly, but if you look at the cost of right now, what it costs to live in assisted living for people your age and my age, it might be worth that investment to start thinking about that now as opposed to later.
Absolutely. Well, and you know, we're dealing with a lot of caregivers who have given up, they've given up their careers, they've given up their homes, and some of them have given up their marriages to care for their, you know, their parents or their aunts or their grandparents or whoever they're caring for. So sometimes, it's the first thing that popped in my head is sometimes those things, if they weren't in place before that, are going to be extremely difficult to implement now. But I guess, you know, knowing that there are different resources out there that you just have to really just, I don't know, I suppose you just Google resources for family caregivers or resources for caregivers.
Probably funding would be funding for assisted living or funding for taking care of your loved one. Most hospital social workers, probably even hospice social workers and agency social workers would be an abundant source of information for that. I try to make myself in the know and stay on top of those kind of things, you know, like our Valley area on aging. You know, if your income is low and you need placement and you've stayed in the hospital for 3 days, oftentimes Valley area will kick in and provide some funding that way as well. So I try to definitely reach out to my local agencies so that I know what's going on there. And I try to, you know, subscribe to a couple of different things like veterans and stuff like that so that I can read when there's changes so that I can alert my families right away. But, you know, again, that's just the patient population that I service. I definitely try to hop on places like this and get that information out there, especially when I'm reading. I just kind of, you know, pop in with a comment here or there to families and to people in there as well.
Absolutely. I think that's so great. We also have, do have a social worker in the Caregivers Hub. If you need her, you can approach me for her name. I'm not going to put her on blast today. But so just know that if you are part of the Caregivers Hub, you have access to people like Laura and to MSWs and nurses. By the way, medical social worker, MSW, that's what an MSW is. But you have access to those medical professionals. So make sure that if you have any of those questions that you are throwing them out into the hub, and we can tag all of the awesome people that are in our group to help you. If you are in the hub, make sure you plug into the files. Every single day, I'm encouraging people, if you have information to share, if you have resources to share, make sure that you are going into the hub and creating a file, because that's where all the good stuff lies. We have advanced directives. We have all sorts of stuff, information in there. So make sure you plug in there. Laura, is there anything else that you want to talk about before we skedaddle here?
No, I think I've done what I came to set out to do. So is there anything else that you'd like to ask me?
Let's see. I'm trying to think. We talked about assisted livings, and that's one thing I was thinking about earlier. I was like, "Ooh, you owned an assisted living." Let me think of all these questions. But I think that we did a great job. Oh, you know what? So we did talk about Alzheimer's dementia, and if we talked about it like to the extent that we always want to, we would be here for like a week. But I loved that you said that you were always focusing on the behaviors of Alzheimer's and dementia. And we have a large group of people in our group, because obviously dementia and or Alzheimer's is an epidemic now, as Laura was talking about. People are diagnosed, what did you say, every 3 seconds? There's
Yeah.
That's crazy. That's crazy. So I definitely think that awareness and education about it, I think we're always learning more things. But what I guess the question, if you could, in about 15 minutes that we have here, when it comes to behaviors, what are some questions that people can bring to their doctors to address behaviors? Because one thing that I see a lot of is people going to their doctors, and it's almost as if their doctors are downplaying or not listening to what they're saying about behaviors. Does that make sense?
Sure, absolutely. So I kind of am giggling to myself because anybody that's watching it that works with me in the assisted livings that I go into is probably having, you know, palpitations right now. Their heart's probably fluttering because they know what my response is going to be to that. It's great that you're telling me something. And I appreciate the fact that you're telling me that this person is ill-behaved. but it's also my job to be their advocate. So I very much have to watch out for people who want to, or places or family members that want to sedate.
Yeah, over medicate.
Sure. And that is a problem. I see, you know, it's definitely easier to take care of somebody who's quiet than to take care of somebody who's, you know, taking your folded towels and unfolding them. So I definitely have to be very cautious. So what I tell people in the assisted livings that I go into, or even family members that are caring for their loved one, I appreciate the fact that you're telling me. I understand that that must be very frustrating for you. But I think what we need to do is I think we need to develop a log. And so I'll hand them the log that I carry with me. And I say, this is how I want you to document on your loved one or on your patient or resident for at least a good solid week. And that should give us the answer. Is this sundowning? Is this, you know, a certain caregiver? Because there can be lots of reasons why somebody is ill behaved. You know, it might not just be the fact that their dementia has worsened. They might have a urinary tract infection, or maybe they just don't like Jake, who's on first shift. You know, I mean, for whatever reason, there is a reason, or somebody is irritating them, or they don't like to be at 7 o'clock for their bath,
or they're in pain.
Yes, absolutely. We spoke about that beforehand. You know, definitely doing a pain assessment on a person. But what I want to see is I want to see that happen more than once. And I'm not going to let anybody suffer personally. I mean, I don't know everybody else's philosophy, but I'm not going to let anybody suffer. I'm not going to let the patient that I care for suffer, and I'm not going to let a family member suffer thinking that their loved one is suffering. So usually by the time that I explain that there's multiple reasons for behaviors, but that the best thing that we could do for the patient is to develop a pattern and see where it's happening and what's happening, that's going to help me most appropriately treat that behavior if I do need to use some of the antipsychotics, or if I do need to add some of the anxiolytics. I need to know when they're happening, because as a prescriber, it's my responsibility to use caution and do what's best. So by, you know, I don't know what anybody else's doctor might want, but by creating a small behavior log and taking that to your physician and saying, I have documented my loved one's behaviors. Here they are. I've made you a copy, and I'd like you to read over them. This isn't just a one-time event. This isn't just a two-time event. Please take this, and then if you need me to follow up with a phone call to you, or if you'd like to follow up with me for any more further questions, I'll be more than happy to answer that. But that gives that provider something to use in their hands, as opposed to just your word of, my patient's having, or my loved one's having behaviors, you got to do something about this. Well, that's great.
Right.
We can. But
what do I need to do?
Absolutely. I mean, there's nothing worse than, I know you said, I think you said lorazepam. And that Ativan is definitely a medication that we can use, and it's definitely an appropriate medication that we can use. And if you go to your doctor, depending on what your doctor thinks, they may or may not prescribe that, but they may tell you to use it 6 times a day, and your loved one's only having a behavior at 12:30.
Right.
So now you're giving your loved one a medication that's appropriate, but at 12:30 only, not 6 times.
Right.
So I think that the best thing you can do is arm yourself, provide your provider knowledge, and then that way you're going to get the answer, you know, hopefully that you're looking for. There's also other things too for people who are a little bit harder to treat with their behaviors. And I know I told you this before we got on the call. I love behaviors. It is my specialty. I love to be challenged by behaviors. But there are genetic tests you can do as well. There's a wonderful company called GeneSight. It's a quick swab on the inside of the cheek. You put it in the envelope, you send it off, and it will give you a list of your loved ones or patients, you know, yes medications, no medications, and use with caution. So it's going to give you suggestions about what might be best to use in your patient that you're having difficulty in managing behaviors.
Interesting. I've never heard of that.
little hidden gem.
That's crazy. That's crazy. That's awesome. So I guess, for you caregivers out there, I love what she said, because oftentimes, as a CNA, we're always looking at our documentation and how are we going to phrase things and document things that is going to paint a clear picture about what we see, what we've done. And from a clinical aspect, we're always doing that to cover our asses, just so you know. But I love that Laura talked about that, because if you haven't started a log with all of that information, that is a great thing to do, to take to your primary care provider. And Laura's given you some awesome tips about that. But another thing that I want to add is I feel like, and maybe Laura, you can piggyback on that, but I feel like if you do all of these things and you go to your primary care provider and they're absolutely disregarding your information that you're giving them, or they're not being effective in handling those things, which can sometimes happen, I would suggest to keep on looking within your network until you find a provider who's going to take you and your loved one or your patient seriously and work together with you as a team.
And it's definitely not inappropriate to ask your provider if they're comfortable caring for geriatric patients. You may find that your loved one has gone into the hospital and came out, and you maybe weren't so involved with their care and suddenly found out that they've been very negligent of themselves. And maybe their mind has slipped a little bit more than what you thought, and they haven't been caring for themselves as well as what you thought. And you take them to their primary care doctor to only find out that they've not seen Dr. Smith in 15 years.
Right.
Well, Dr. Smith may not be comfortable, caring for geriatrics. He may be a family practitioner, he may be an internist, but maybe that's just not his passion, or it's not his driving force to why he does what he does. There are plenty of geriatric providers out there, gerontologists. So I would urge you to look for one of them, or there's nurse practitioners out there who are geriatric certified. So I would encourage you to find them and make sure it's your responsibility to interview them just as much as they interview you.
I love that, because it goes along the lines of, I always have patients sometimes who say, well, like they've accepted poor care because they don't think that they have a choice, that they have the right to say, and I always tell that to my patients, especially if I get complaints about another HHA or the care provided over the weekend, I always encourage them to call our hospice and, request a different CNA or request a different nurse or request whatever, that they don't have to just accept subpar and inadequate care. And so that's the truth for all of you caregivers out there. You don't have to just accept subpar care from your aide, your nurse, your ARNP, or your doctor, your primary. So I think that we covered a lot of ground. And if you have any questions for Laura, you can have access to her within the Caregivers Hub. If you're watching this and you're wondering where can I have access to the Caregivers Hub, the link will be in the bottom of this video, as well as on the Facebook fan page, Caregivers Hub. Just type in the Facebook search. And there's a link to a lot of different groups, actually. So make sure you plug in. Next January, technically next year, so I'm kind of having the feel out. I got this book from this doctor. His name is Dr. Sloan, and he wrote, I can't remember the name of it. That's horrible. But it's like, it's a pretty good book, and it has all of the A to Z of dementia and Alzheimer's, from behaviors to bedbound care to wound care to patient rights. I mean, all of these things. It has a really good overview of a lot of good information clinically for Alzheimer's and dementia and just care in general. I'm working on getting him on the Caregivers Hub Hangout next month. However, if I don't, my backup plan is I want a panel of 10 of you, whether you are a professional caregiver or you're a family caregiver, or you just want to talk about caregiving. We're going to come out. This hangout can hold up to 10 people. And I think we're just going to hash it out and talk about about what we go through as caregivers and all the good stuff. So on that note, I'm going to hand it off to Laura to say goodbye, and we're going to move on with our badass selves and do some good work as caregivers and nurses and CNAs and all that good stuff. So Laura, come on out. Say goodbye.
Thank you, everyone, for having me. I will drop the behavior log on Facebook. So for those of you that want to use that, I'll drop that there later this week. If you have any questions, drop them in there, and I'll try to get to those later on this week. Thank you so much for having me. It was a pleasure.
Oh, you're so very welcome. Anytime at all, this is your soapbox. This is all of your caregiver soapbox. I promise you always have this platform to come out and speak your mind and how you feel about healthcare and caregiving and what we go through. Yes. So you can create a file, Laura, if you want to go in there and just drop all that stuff in there. All right, lovelies. I'm going to peace out. And so you guys have a great week, and I'll see you next time around.